Our first speaker is somebody that's very, very dear to me. I've had the pleasure of having him as a physician with me for 32 years. He started with me when I started with lupus and ITP, and he was my hematologist and then became my oncologist for my NET. He also has taken care of every family member that I have ever had that has had cancer, our friends and everything else. So he's very dear to me. He knows a lot about NETs. I believe I wouldn't be standing here today if it wasn't for him. And so I am eternally grateful forever to Dr. Hal Gerstein. So Hal, come on up.
Well, thank you. That was more than I deserved. First thing, thank you all for coming. I see very many old faces, some new faces, and it's a pleasure to see everybody again. You may be wondering, why me? I'm a local medical oncologist. I see all kinds of cancers. How did I get involved in this? Well, Mary Ann just told you why. She has that magnetic personality and that forceful personality, and she said to me, you have to learn about this cancer. I had to learn about it, and that's why I'm here today.
You forgot the 4 L's.
So, how many people here know how the term carcinoid came to be? Does anybody know? Okay, you do. Good. So for those who don't know, the term was first characterized back in 1907 by Siegfried Oberndorfer. He was a German pathologist, and he noticed under the microscope of some cancer specimens that they looked like carcinoma, but the patient's tumors behaved in a more benign fashion. They didn't seem to be growing very rapidly. They didn't have a high mitotic rate, etc. So he coined the term carcinoid, which means carcinoma-like. It wasn't until a couple of decades later that the endocrine-related properties were first noted, and then even after that, they found that these cells stained in a unique fashion with a stain called enterochromaffin. And when I was back in medical school in the 1970s, and don't try to guess my age because you won't, that's how I learned about it. These were enterochromin staining cells. That's exactly how they were defined in the medical textbooks, and nothing else. It wasn't until even decades after that the World Health Organization started classifying these tumors in a unique fashion. Can I have the first slide, please? Next one. Next one, please. Where is it? Oh, that's it. That's it.
Yep, that's it. Yes.
Got it.
Technical difficulties. Let's take a peek and see what we got. Oh, there you go.
Where am I aiming it at?
Up front.
I'm aiming
Down
it,
button.
I'm aiming it there?
Yeah.
Okay, got it. Okay, thanks. Down button. I got the down button. There we go. Okay. So the neuroendocrine tumors are really a diverse group of malignancies. They arise from those enterochromaffin cells that we mentioned, and they can arise anywhere in the body. NETs can present with functional and non-functional tumors, and a group of symptoms that we now know as the carcinoid syndrome. This is not going to be fun. Oh, there we go. Okay. All right. So the proper term now for these tumors are neuroendocrine tumors, not carcinoid tumors, because they're not all behaving as carcinoid symptoms. They can go years without detection because it takes a large amount of tumor to produce some of these symptoms. They can arise in the pancreas, and we know that as PNETs, or other GI tract areas, the foregut, the midgut, and the hindgut. No, wrong one. Okay. We know that this is an older slide, but it still holds true today, that the incidence of NETs is rising faster than other malignancies. And that's probably because of our better diagnostic procedures and our awareness in identifying these tumors.
The light show is free.
They're increasing in all areas, in lung, appendix, stomach, colon, small intestine, rectum, etc. So it's not just confined to one organ. And it's not unique to the United States. The incidence is increasing worldwide. We make the diagnosis using morphology, the same way that Obendorfer did way back in the last century. We make the diagnosis by grading the tumor, whether it's a high-grade or low-grade tumor, and we do immunohistochemical staining for chromogranin and synaptophysin. So the pathologist will give us all this information when he reviews the tumor. Gastrointestinal and pancreatic neuroendocrine tumors are generally classified into well-differentiated or poorly differentiated tumors. Ki-67 is mandatory for grading these tumors. It's very important to make sure the pathologist gives us an accurate Ki-67. Okay. So disease stage, tumor grade is used as well as Ki-67 and the mitotic count for prognostic parameters and should always be assessed. We also use the TMN system we use commonly used in oncology to stage our tumors. That is the size of the tumor, whether there's lymph node metastases, those are regional metastases, or distant metastases. CTs are the basic radiological method for NET imaging, but we're limited by the size of the tumors, bone metastases, and small peritoneal mets. They may not be detectable easily by CAT scan. MRIs I find much more useful for examination of the liver and the pancreas, and that's the preferred method for staging in those areas. MRI may be also superior to CAT scan for imaging of the bones and the brain, but CAT scan remains the better tool for lungs. When we're looking at PNETs, endoscopic ultrasound is the best way to look at the size of the tumor and the location of the tumor. You can also use endoscopic ultrasound to biopsy these small tumors prior to making a determination as to the next step. PET scans. Well, PET scan is an interesting topic for neuroendocrine tumors. Traditional PET scanning is FDG PET scanning, which is a glucose-based PET scan. I do not find it that helpful for staging neuroendocrine tumors. Much better are the gallium scans, and now we're transitioning to the copper scans. It's simply a different radioactive isotope, whether it's gallium or copper. The scans are basically the same. For those who don't know, a PET scan is a fusion scan. The PET part of the scan tells us if an area in question is functional, that is, it's active or growing, and the CAT scan tells us the anatomical area, whether there's a mass there or not. The fusion scan puts them together and gives us a lot of information about the lesions. Okay, so in summary, disease stage and tumor grade, we did this already, did we do this one? Yeah, disease stage and tumor grade according to Ki-67 and mitotic count, those parameters are very important in assessing prognosis. We use the TMN system, we use CAT scanning as the basic method, especially, and we're looking at the lungs. The MRI is preferred imaging for the liver, pancreas, bones, and the brain. Endoscopic ultrasound used for the NETs, and I'm sure Dr. Sasson will talk about intraoperative ultrasound, which is commonly used before pancreatic resection. Okay, so neuroendocrine tumors, we know that the incidence is increasing, which is disconcerting to all of us. However, notice that we're diagnosing them earlier. Localized disease is being picked up much more commonly now than before. I'm in a lot of trouble with this. Be that as it may, 50% or more of tumors are still not diagnosed until they're spread either regionally or distantly. And the reason for that is because it takes time for these symptoms to expose themselves to us and make us look for these tumors. And how long that time is on the axis on the bottom, that can be months, years, or decades for the tumors to grow large enough to cause abdominal symptoms or spread either locally or distantly to cause symptoms such as flushing or diarrhea. So we still have to try to make this diagnosis even earlier than we're doing. Oops. Okay. So going back to the World Health Organization classification of these tumors, we see that the prognosis is based, going from left to right, from well-differentiated tumors to poorly differentiated tumors. The well-differentiated tumors with the best prognosis are those with a Ki-67 of less than 2, no metastases, no infiltration or invasion of local blood vessels. And tumor size can be either small or large. So tumor size is the least important in prognosis. For poorly differentiated tumors, they have a high malignant potential. They very often present with metastases. They have a very high Ki-67. They do show infiltration of the local tissue and of the local blood vessels, and they can be of any size. So the poorly differentiated with poor prognosis can also be small tumors. Keep going. survival is associated with stage, and that makes sense to all of us. The later stages have a poor survival, and the local disease with early stage have a longer survival. We should note, I just want to make one more point, is that survival here, we're looking at months. So survival, we're looking at 10 years or more for a majority of patients. Pushing the wrong one. Okay. Survival is also associated with tumor grade. Well-differentiated tumors have a longer survival. Poorly differentiated tumors, a shorter survival. Take-home points from these slides are neuroendocrine tumors are malignancies that arise in patients, in cells whose normal function is to secrete peptides, that is functional, that makes them functional, although not all do. The median survival is 33 months with advanced disease. Even small tumors can become metastatic, and that's where tumor grade is our most important factor. So how do we approach these tumors once the diagnosis is made? Cancer therapy is traditionally based on surgery, chemotherapy, and radiotherapy. Our newest weapon is immunotherapy, which really won't come into play yet for neuroendocrine tumors. Okay. For local regional disease, surgery is the treatment of choice. That's very hard for a medical doctor to say. Surgeons love to operate. Medical doctors don't. But the truth of the matter is, surgery is always the number one choice for these tumors, especially if they are localized tumors. Okay. For pancreatic neuroendocrine tumors, it's kind of a unique situation. For small tumors, less than 2 centimeters, a watch and wait strategy for those asymptomatic patients, that is a non-functioning tumor, can be approached with caution, especially in patients who are elderly or have comorbidities. For younger patients, or where there are signs of local invasiveness, a surgical resection with a pancreatectomy and lymphadenectomy is mandatory. For functioning pancreatic tumor, surgery is generally used as often as we can. Again, pancreatectomy with regional lymphadenopathy is recommended for those tumors that are greater than 2 centimeters. And for patients with small lesions, and if we can't watch and wait, then we can do an enucleation, which is just removing the tumor itself and not worrying so much about the lymph nodes. For small intestine neuroendocrine tumors, we generally deal with macroscopic resection if they are localized, because this reduces the risk of further intestinal complications. Neuroendocrine tumors tend to cause a lot of fibrosis in the mesentery, and removing the tumors as much as we can will tend to minimize that. Those kind of complications are bowel obstruction, which can be life-threatening. The surgeon will generally palpate the entire intestine and be able to feel and locate any lymph nodes. Should he find any lymph nodes, he should resect them if possible. So what do we do after a surgeon is completely successful in removing the tumor? And it does happen, and it happens quite often. And then we're presented with a case of a patient whose tumor has been completely resected. And the next question that is asked is, what do we do now? How do we prevent this cancer from coming back? We all know that cancers have a tendency to come back. They recur. As of today, there's no data from any prospective randomized trials to show that there's any adjuvant therapy that will prevent this from coming. So we tend to do a very careful monitoring program, which I'll go into it later on. For aggressive tumors, there is some evidence that platinum-based chemotherapy may be effective. But again, it's not standard of care. For metastatic disease, surgery should always be attempted if there's potentially resectable liver metastases. Also, palliative resection of primary small intestine tumors in advanced disease can also be entertained to prevent complications related to bowel obstruction or ischemia, which is dying intestines. You can also do surgery to alleviate the symptoms of carcinoid syndrome in patients with functional NETs. It's a way to reduce the tumor burden and reduce the production of the functioning peptides. We can also use local regional treatments such as ablation, embolization therapy, etc., as an alternative to resection in patients with liver metastases who are not eligible for complete resection. In certain circumstances, we can combine resection and ablative therapies. Okay, so let's move on to medical therapy. Medical therapy is used for advanced disease. The goal of medical therapy is twofold. One, we try to contain or alleviate tumor-associated clinical symptoms. We know that as carcinoid syndrome. And two, we try to limit, control, and decrease tumor growth. Standard first-line therapy for functioning neuroendocrine tumors are the SSAs. Octreotide, LAR, better known as sandostatin, or lanreotide. Those are our first-line therapies. Sometimes we still add interferon as a second line or as an add-on to the SSAs. Teleretristat or Zermello can be used as an add-on as well to an SSA. It's never used alone for incompletely controlled carcinoid syndrome diarrhea. Zermello is very important medication because it will significantly lower the serotonin levels for patients, and that has a very important impact on carcinoid heart disease. We can use PRRT for symptom improvement, but sometimes PRRT, if not used properly, can cause an acute aggravation of symptoms, and PRRT is I'm going to reserve talk for that for Eric's presentation, but we generally use that now for control of tumor size. Other treatment options for uncontrolled symptoms include the TKI inhibitors, everolimus, sunitinib. We use diazoxide for insulinoma to control the insulin levels. We use proton pump inhibitors for gastronoma, and we can still use SSAs for Zollinger-Ellison syndrome. Okay, and pancreatic NETs, we can also use the SSAs. Usually lanreotide is the treatment of choice for pancreatic NETs, as well as PRRT. For those patients who have gotten or are anticipating PRRT, the SSAs are still used after PRRT in most cases to control the production of our peptides. So the second objective in medical therapy is to control the tumor growth. That we call that AntiProliferative Therapy, and the use of these drugs, I'm not going to give you an order to use it because the sequence is completely dependent on individual patient factors as well as physician choice. But we use SSAs for tumor control. and we can use sometimes watch and wait for those with a low tumor burden. It's important to note that using SSAs for tumor control is not totally dependent on whether or not the positive receptor status is identified. So even if those patients who have demonstrable tumor but are not lighting up on a gallium scan can still benefit from SSAs. The TKIs are used for progressive pancreatic neuroendocrine tumors, everolimus for pancreas, sunitinib for pancreas, as well as some GI neuroendocrine tumors. They do have some significant side effects, though. They can cause mouth sores, diarrhea, fatigue, sometimes infections, and pneumonitis. They should not be used without good medical monitoring. Okay, chemotherapy. Chemotherapy is less used now than ever before. However, it still can be used in advanced pancreatic neuroendocrine tumors and some GI tumors that are highly aggressive, poorly differentiated. The agents that have been used in the past include streptozotocin and 5-FU, but more recently, Temodar or Capten, which is capecitabine and Temodar, is used. For poorly differentiated tumors, platinum-based therapy with etoposide can also be used. Eric's going to go into PRRT a little bit more detail, but PRRT, which is peptide receptor radioactive therapy, is an option for those patients who do have positive gallium scans. It's approved for midgut NETs and pancreatic NETs, but it does have some significant toxicity, and it was first approved as second and third line therapy, but it has moved up in the armamentarium and is being used earlier and earlier in intervention. So this algorithm is very complicated and goes through a lot of different options for our patients. So the question is, what's the sequence? How do we deal with all these options that are now available to us? And the answer is, there is no standard approach. Everything should be individualized for each patient, and there are various factors to take into account, whether the patient has symptoms of carcinoid syndrome, whether the patient has symptoms from bulky disease causing discomfort and pain, which organs are involved, where in the organs they're involved, etc. So all these factors have to be taken into account. How do I follow my patients? So this is one question that's often asked to me, and what I do for my patients is whether or not they're receiving therapy, every 3 months they get a panel of blood tests, which include blood counts, liver chemistries, kidney function tests, thyroid function tests, and of course the tumor markers that we use to follow our patients, which are serotonin and chromogranin A. There is some controversy on how accurate some of these tumor markers have been. So I generally use trends in patients rather than absolute numbers. As far as imaging, we'll do a CAT scan or an MRI every 6 months for patients with stable disease. Should the clinical situation of patients change, should symptoms exacerbate, then we may, of course, speed up these tests. How long do we follow our patients for? Well, I follow my patients lifelong, but in some patients you can extend these intervals quite a bit. One thing that is not on this slide, and I'm sure somebody's going to be asking, is when do we repeat the gallium scan? And I'm going to tell you my approach, and Eric may have a different approach to this, but my approach is I don't repeat the gallium scan unless something is showing up on a more standard scan, like a CAT scan or an MRI, and I'm not sure what this new lesion may be. Not all lesions may be neuroendocrine tumors. Some things may show up on an anatomical scan that may be benign. If there's any question on what a new lesion is, then you want to do a functional scan, like a gallium scan, to see if it's related to the neuroendocrine tumor. But in general, I won't rush into doing gallium scans on a routine basis unless I'm prompted to. Small, localized, less than 1 centimeter neuroendocrine tumors who have had a complete resection and have good prognostic features don't require much in the way of follow-up. So the gist of what I'm trying to say here is that nothing's etched in stone. Every patient's different. Every approach to every patient has to be different. And sometimes you'll get different approaches from different doctors, and that's a good thing. We should take advantage of all the resources that we have, including NCAN, including our regional experts in university centers, as I do, to get other opinions and see what different approaches might be. There's always an alternative. Sometimes every choice can be a right choice. It all depends on which pathway the doctor and the patient want to take together. And to leave on a good note, patients with cancer in general are living longer than ever before, especially neuroendocrine patients. For oncologists in general, we've taken a turn to focus on quality of life in addition to quantity of life. For neuroendocrine patients, that's been a focus since the beginning. So you guys have taught us a lot on how to deal with patients. You guys have taught us that we need to look at your symptoms and quality of life, which is as important as anything else. People with cancer want to live normal lives, not just lives, but normal lives. And new treatments are becoming available every day. And we see that more and more with neuroendocrine tumors. And I thank you very much for your time.